Welcome to another episode of Reboot with Dr. Arasi Marin. I'm your host, Dr. Arasi Marin. I'm a board certified general and interventional cardiologist, which basically means I fix blockages in people's blood vessels. I'm also an associate professor at the Medical University of South Carolina and the director of the Complex Coronary Intervention Program. But this mission is completely separate from my university and hospital duties. The goal of this podcast is to improve health awareness to the public and inspire people to take control of their health via evidence-based scientific facts. Today, I have a very special guest with me, Dr. Yasmine Ali. She wears multiple hats. She's a board-certified cardiologist and also holds a degree in Master's in Science Clinical Investigation. She is an assistant professor at the University of Vanderbilt. Dr. Ali, welcome to the podcast. You have so many different hats. I don't know where to start. I think I'm completely impressed that you, apart from all your other medical publications, you have a book, Walk Through Fire, a train disaster that changed America. I mean, basically talking about the origin of FEMA. That's impressive by itself. And you were in Medscape. Medscape has kind of been our go-to site for all evidence-based medicine. You were you were in charge of the atherosclerosis section, the congenital heart disease section for several years. And you were also part of the verywellhealth.com. You were the obesity expert as well. And now to add to all this, you are now having a site of your own, Speak from the Heart or Speak for the Heart, where you provide insights and newsletters. I mean, is there anything you don't do?
Thank you, Dr. Marin. You're so kind. It's a pleasure, let me say. It's a pleasure to be with you here today. And I really admire all that you have done too. So you're a very accomplished woman in your own right.
Thank you. Thank you very much. So, I truly before we get into the meat of this podcast, I'm curious about your journey. How did you navigate these different paths? And, just tell me a little bit more about yourself.
Oh, well, okay. So cardiology was something I probably was always meant to do because we have a picture. So let me back up. My parents are both physicians, and there's a picture of me when I'm 3 or 4 years old that we have, and I have my father's stethoscope in my ears, and the bell of the stethoscope is over my heart. So I am, I know that I have it in the correct position. I was listening to my heart. So that early, I was fascinated with the heart. So I think I always knew I was going to be a doctor. And I always also loved to write. So I was also a writer really since the time I learned to write. I was writing stories and essays and poems and that, just continued. And so then, I went to medical school. I had taken in college a human physiology course, and I loved cardiovascular physiology, the circulation and the way the heart works in the body. It just really captured my fascination. And so when I went into medical school, I kind of had that in the back of my mind as well. And every course I took that, anatomy, physiology, histology, all these things we have to take in medical school, whenever we got to the heart, it just really resonated with me. And I'm sure that you can relate to that as well, And so, I went to internal medicine training, knowing I was going to go into subspecialty as a cardiologist to do my fellowship as a cardiologist. And I did medical school at Vanderbilt, went to UVA to do internal medicine, University of Virginia, and came back to Vanderbilt University to do my cardiology fellowship. And Vanderbilt had a very special program at the time, a Master of Science in Clinical Investigation, where you could learn how to do clinical research and write about clinical research and read the medical literature and all of these things. And you could do that in conjunction with your cardiology fellowship. So I made my fellowship 4 years, got the MSCI degree while I was doing my fellowship, and really got an interest in preventive cardiology, which I have to say is something that started when I was at the University of Virginia in internal medicine. I met these wonderful preventive cardiologists, worked in their clinics on all my elective months, pretty much. And for those who may not know, preventive cardiology is trying to prevent heart attacks and strokes and the bad outcomes of heart disease. And so trying to get on the front end of things, because what I realized is that, and you've seen this too, I know that by the time you get to having a heart attack, you're doing damage control at that point. And I really wanted to be on the front end preventing that so people could live healthier lives and not have to go through, the the catastrophe of a heart attack or heart failure or having to live with that. So I really devoted my career to helping people live better quality of life, preventing heart disease, improving longevity with quality. That's really important to me, healthy quality of life. And so one of the things I did was get advanced training in preventive cardiology officially when I was doing my fellowship. I also got advanced cardiac imaging training. So that at the time was cardiac CT and MRI. And I was Vanderbilt's first advanced cardiac imaging fellow, as a matter of fact. So also got training in nuclear medicine. So when people go for a stress test and we get images of their heart in the big nuclear scanners, I got advanced, we call it level 3 training in that. So yeah, very steeped in my cardiology training, but I never forgot my writing. Any writer will tell you it's something you just can't not do. So you have to do it. It's just a part of you. And so I've continued to do that. And I found a way to marry my love of cardiology with my love of writing by digital writing, writing for blogs. When that became popular, I started my own blog, and then I wrote for Very Well Health, and I helped out Medscape, as you mentioned. And now I have my own blog again called Speak for the Heart. And I do a weekly newsletter that goes out for the general public just so they can understand all the many different things we can do in a positive way to help our hearts and keep ourselves healthy. And so at the end, remind me, I'll tell your listeners what the website is, how they can find that.
We will put all of that in our show notes page. So anyone who wants to know more can click on that and get all that information. We'll put your website, everything. So, that'll all be there. So
that's terrific. That's very kind. So yeah, so I've found a way to marry medical writing is sort of what the writing I do, with my cardiology expertise.
So, I think you and I are in two ends of the spectrum, right? You don't want heart attacks to come. I damage control once the heart attack comes. How do we fix that? So you and I are fighting the same things, but on the other end. And I think it's wonderful that we both are in the same space and kind of preaching the same thing, that prevention is definitely better than a cure. And you don't start prevention at 70s and 80s years of age, but you start in your 20s and 30s and 40s. And hence the name of my podcast, Reboot. It doesn't matter how you have been, it's okay, and you can reboot. So, we are going to assume the people who are listening to the podcast don't know anything about cholesterol, anything about lipid panels. So we're going to start at that basic level and kind of build it up as you go. Everybody talks about cholesterol, or good cholesterol, bad cholesterol. Can you kind of give us a brief overview of cholesterol itself, or the lipid panels and the different things we measure within a lipid panel?
Right. And so people know when we talk about a lipid panel, that's commonly known as the cholesterol panel. So for a general audience, that's really the same thing. You could think of lipids as cholesterol. So that's what we're talking about. And in a lipid panel, we look at various kinds of cholesterol in the body. So the typical measurement is the total amount of cholesterol, that's total cholesterol. The HDL cholesterol, high density lipoprotein, HDL, is often thought of as the good cholesterol, because in most people, the higher your HDL, the less your risk of having heart disease. And by heart disease, in this case, I mean blockages in your coronary arteries, okay? And then there's the LDL cholesterol, low density lipoprotein, and most LDL cholesterol is thought of as bad cholesterol because it infiltrates the walls of your arteries, it allows plaque to form there, and that lets the arteries become blocked later on. That's clogging of the arteries, atherosclerosis. And we know from study after study after study over many decades now that the lower your LDL, the lower your risk of heart attack and stroke, as a matter of fact. So lower LDL is better, higher HDL. So I think of H for high, you want your HDL to be high, L for low, you want your LDL to be low. Then there are the triglycerides, which are really the fats in the bloodstream. And the higher your triglycerides, that's also a risk factor for heart disease and heart attack, but it's also a risk factor for pancreatitis, inflammation of your pancreas. It can also be a sign of diabetes. So you also want your triglycerides to be low, and eating fatty foods, fried foods, sugary drinks, those things will all raise your triglycerides. So those are the four main components of the lipid panel that most people would think of.
Absolutely. So now, there's a lot of drama about LDL, right? And there are groups of people saying LDL is actually not the bad cholesterol. Do you ever blame the firefighter who rushes to the scene of fire and damage controls, and LDL is like a damage control lipoprotein and not necessarily causing inflammation? What do you like to say to those side of the audience?
So you bring up a really great point. I'm glad you asked this. I'm a clinical lipidologist, board certified in the study of cholesterol. And so I can tell you that there are really two different categories of LDL cholesterol, two major categories we can think of. One is small, dense LDL, and that's very bad. That's the kind that gets into your arteries and causes the clogging. And then large, buoyant LDL, which doesn't seem to be as much of a risk. The problem is on the normal lipid panel, the regular routine panel that most doctors order, you can't tell the difference. The LDL is just reported as all of the LDL value. And so we treat to lower that LDL. And what the studies have shown is that treating that high LDL, even without separating it out, results in less risk of heart disease. So we continue to treat that. And personally, I want my LDL lower than 70. And I don't care too much whether or not it's small, dense, or large, buoyant. I just want the number less than 70, and I feel good about that because I know, the studies have shown that I will have less risk of heart disease, stroke, every other, bad thing with the heart, with the coronary arteries, if I just keep my LDL low. And what we've seen is that people who follow good diets tend to have lower LDL too. So, these things all follow along. Now, if you wanted really to tease out the different kinds of LDL, you can have you can ask your physician to do an advanced lipid profile, and they can really tease that out. But that small, dense LDL is really a problem, and there is no debate in the scientific literature anyway that is a cause of inflammation and atherosclerosis.
So now we'll talk about medications in a little while, but before medications, this basically, we don't want patients to be on medications. So we want patients to, stay healthy or don't become patients and just take care of their health. What would be, the first line of treatment is lifestyle management. But we never, go into, we just saying, go home, eat better, move more is not going to cut it. So what dietary habits can directly affect the cholesterol levels?
Yes, and that's exactly the sort of thing I try to go into every week in my newsletter, because you're right. As doctors, we don't provide enough information as to how people can practically do this in their everyday lives. And so there are, the main things we talk about are diet and physical activity. And diet makes a really, really big impact on LDL in particular, in terms of, what is a healthy diet? So I point people in two general directions. One is the DASH diet, DASH, DASH diet. It's dietary approaches to stop hypertension, which is high blood pressure, but it also lowers cholesterol. And this is a diet that was designed by the American Heart Association many years ago and has been shown to be one of the best diets in the world for preventing heart disease. The other is the Mediterranean diet. And there's a lot of information on that. And it's actually the diet that I follow because I find it to be quite delicious and very healthy. It's both the DASH and the Mediterranean diets, which anyone can look up online. There's so many great recipes and information out there now. But both of those diets are heavily plant-focused, plant-based. And so I always tell people plant-based doesn't necessarily mean that you are a vegetarian, but it means that most of your plate is made up of fruits and vegetables rather than meat. And so if you also take it further and try to avoid red meat or eat red meat no more than once a week. And by red meat, I mean pork, beef, lamb. What am I forgetting? Pork,
Goat.
beef, lamb. Yeah, those are the main ones. And so if you prefer, it's better to eat poultry, or even better than that is fish. So personally, I'm a pescatarian, which is someone who eats fish as their meat protein. Those are much better for you than eating red meat. So 5 to 7 servings of fruits and vegetables a day, at the very least, is what's recommended internationally for both improving your heart health and lowering rather your risk of cancer and obesity and diabetes and and high blood pressure and all these other, chronic diseases. All of it can be traced back to diet in many cases. If you just increase the number of plants you have on your plate, just focus on that, you'll do really well.
So the biggest problem is people seem to manipulate the term plant. Okay, I come from India. India is a country filled with vegetarians, but we have the highest increasing rates of diabetes and cardiovascular disease because the plant-based diet has been completely warped. It's more of grains and wheat and flour, and the amount of green leafy vegetables and the colorful plants and fruits has come down, and the more beige colored plant-based foods come up, and they think that should be good enough, but that is not what DASH diet is recommending or the Mediterranean diet is recommending. What we both are speaking the same language, that the plate should be with actual vegetables which grow, and the fresh vegetables and fresh fruits, and not necessarily flour-based vegetarian stuff. Am I
absolutely? The colors of the rainbow. Get the colors on your plate. Your plate should have at least 3 different colors on it. So you're right. If you're having a meal that's all beige or white, that's not what we're looking for. And you make a really good point about flour. A lot of flour that people consume now is highly refined. Well, it's great to have whole grains. Let's not forget that. Quinoa, barley, whole oats, those are really good and important. It's important to have fiber in your diet. But that's not necessarily the plant-based diet that we're talking about here. So while I do try to get whole grains, when I talk about fruits and vegetables, I'm not talking about wheat as a vegetable. I'm talking about
as a vegetable.
Right. I'm talking about broccoli and cauliflower and lettuce and spinach. Right.
Because it's all open to interpretation, right? Potato chips is vegetarian. So vegetarian pizza will be vegetarian, but it's pizza and it's flour and there's no nutritive value to it. And the fact that American school system recognizes tomato sauce as a serving of vegetable is appalling, but that's a different matter.
So we have gotten away, especially not only in this country, in many countries, you've mentioned India and other places do this as well. We have gotten away from whole foods and moved so much toward processed and refined foods.
Absolutely.
And what we are finding more and more now is that if you've got a vegetarian diet that is full of processed foods, it can be processed plant-based, it can be Beyond or Impossible burgers. Those are highly refined processed foods with preservatives and the nutrients taken out of them and all kinds of chemicals that isn't helpful either. And in fact, there was just a study that came out, the European Society of Cardiology meeting last week at the Preventive Cardiology section showed that eating these plant-based burgers or meats like plant-based sausages is actually no better for your heart than eating regular red meat.
Absolutely. And I think just now I was reading the news while waiting for our podcast to start that Italy is the first country to ban Bill Gates' artificial or synthetic meat. And I'm like, yay. Good for Italy. And I hope more countries follow through because yes, I know Bill Gates probably thinks that, beef control and, cow pollution or whatever, that might be better. But the more we go away from natural, real things into artificial, man-made things, I think we are losing the battle here. And that's why I'm completely against sugary cereal. I even had this battle yesterday with my own daughter who was fighting with me for Raisin Bran. And I'm like, no, it's cardboard. We are not doing that. And that's vegetarian, that's completely vegetarian, but it's completely artificial and there's nothing natural in that box itself. So yes.
Right. I couldn't agree more.
So, we talked about diet and we talked about the things we can change about diet, but there are genetic reasons, right? There's lipoprotein little a, which is getting a lot of buzz right now. Can you talk a little bit about lipoprotein little a?
Okay, I'm glad you brought that up too, because that's a part of the lipid panel that most people are not familiar with. And usually you do have to get an advanced lipid panel or extra testing to find that. But lipoprotein little a is, and whenever you hear the term lipoprotein, that's part of the lipids, the cholesterol that we're talking about. And so that is largely genetically determined, actually. I think I read recently 80% of lipoprotein little a is genetically determined. And if that number is high, if your lipoprotein lipoprotein little a. And the way this is spelled, you'll have to show it in the show notes because most people don't know what we're talking about, little a, you know, but it's lipoprotein with
in brackets.
little a in parentheses. Yes. And we just call it lipoprotein little a. That's how it's referred to in the medical community. But if it's high, you are at higher risk of having a heart attack or a stroke. So cardiovascular disease risk rises as your lipoprotein little a is elevated. And there are medications that, companies are working on now to lower lipoprotein little a. It does seem that if you are able to lower it, you may be able to lower people's risk of heart attack and such, but we are still following that. That's still an emerging story. I think you'll be hearing more about it in the months to come, especially this year. Some drugs that are already out there that we give people to lower LDL cholesterol, like statins, like PCSK9 inhibitors, like Repatha is an example of a PCSK9 inhibitor. Those also lower lipoprotein little a to a small degree, and so maybe they are helping in that way. Lipoprotein little a has been also shown to be associated with inflammation. So, and we know more and more now that atherosclerosis, the clogging of the arteries, is related to inflammation, as you talked about at the top of the hour. So all of that is interconnected, and the short end of it is it's better for your lipoprotein little a to be on the low side than elevated.
Sure. So, we have to kind of briefly at least talk about who are the people who should go to the primary care physicians and ask for, hey, give me the expanded lipid panel and not just the regular one. So, who would be those people?
So what I always did in my preventive cardiology practice was people who had a family risk, especially if they had family members who had a heart attack or had a stent, something like that in their coronary arteries before the age of 55. For men particularly, but anyone really before the age of 55, if they have that history in their family, I would suggest that they get advanced testing. If their lipid profile was sort of on the borderline, let's say, so we couldn't decide because maybe their LDL cholesterol was such that it wasn't extremely high, but it also wasn't below 70, which is absolutely ideal. And we weren't sure whether or not we should be treating them, then we would get the advanced profile. People who have other risk factors. So we really need to talk about that. A big risk factor for heart disease is diabetes. Mm-hmm. And so people with diabetes will usually already be on a statin medication to reduce their heart disease risk. But if they're not reaching their LDL goal on a statin, you might want to consider looking at the rest of their lipid profile, maybe doing an advanced profile, seeing what else we could treat. People with obesity may also want to consider this. And then people who have 2 or 3 or more risk factors, high blood pressure, family history, diabetes, obesity, they may have been smokers or continue to smoke. All of these things add up. And if they are for some reason on the fence about whether or not to start a statin medication, we'll often do the advanced profile to show them. Or if they're already on, like I said, if they're already on one of these medicines and we're not sure if it is lowering them enough, then we might look at the rest of the profile.
So one thing which I don't see in my patient population is because most of them already have stents or have blockages, etc. I always say LDL less than 70. But your population is patients who don't have, blockages or who've not had a heart attack or something like that. So for a regular person, where do you want their LDL to be? Because it differs for different risk factor profiles, right?
Yeah, you're absolutely right about that. So because I'm a cardiologist, because I've looked at this, because I know what happens when your LDL is not low enough, I like mine to be as low as possible. I like mine less than 70. But, that might, for some people who have, genetic or family history of high cholesterol, that might be difficult to achieve without a lot of medicines. And they may not be at that point in their lives where they want to take that on. And so, LDL less than 100 is often what is recommended for most people. That's really, that's fine for most people. Sometimes, especially if it's a young woman, for instance, and she doesn't have other risk factors, we would accept an LDL less than 130. So give that as an example. But most people who would have come to me as a preventive cardiologist are either looking for primary prevention before, and it looks like we have to keep an eye on our time, are looking either for primary prevention because they have a family history or some other risk factors, and so they want to be aggressive about their LDL lowering, or it is secondary prevention. And we need to remember that, RC, too. People who have already been to you may come to me because they want to prevent another heart attack or another stent. And then we're really aggressive. That's where we really want it less than 70.
Absolutely. So I think that is important. And, you briefly mentioned about triglycerides and, the connection between triglycerides and blood sugars. And, therefore, I'm basically bringing diabetic patients and their risk factor profile. And, I always tell the story, because it really stunned me how a 41-year-old diabetic male, uncontrolled diabetes, obesity, everything, had a STEMI, ST elevation MI, and his right coronary artery was filled with clot. We put a stent, and I'm like, hey, we did a great job, etc. And this patient was shocked. How did this happen to me? I'm like, what do you mean? Like, why are you? I was like, what is going on here? Your hemoglobin A1C is 13. Your LDL was like 167 or 170. Your weight is not under control. You have a lot of visceral obesity. How is that you were not aware that this is going to happen to you eventually? And why are you surprised and almost angry at me for telling you you've suffered a heart attack? So can you tell me the role of diabetes? Like in my mind, it's the forest fire, but I would like to get your take on it.
Wow. I love that analogy of the forest fire. And many people don't know this because it's just not in the mainstream education for people that diabetes is one of our greatest risk factors for heart disease, for stroke, for many other things. But we're sticking to heart disease here. And so diabetes causes inflammation throughout the body. And we've talked about how inflammation damages the coronary arteries and makes it easier for them to get clogged with the cholesterol. So all of that is related. Diabetes makes your cholesterol profile worse. So, your LDL may be higher. Your triglycerides will be higher with diabetes. And so those things contribute. HDL, the good cholesterol, is often lower when you have diabetes. So you have that working against you. Diabetes also can cause kidney dysfunction, and kidney dysfunction is related to heart disease. We know that it is related to high blood pressure, and high blood pressure also damages the coronary arteries. And then there's the effect of the sugar itself. High blood sugar in the arteries causes damage. We call it endothelial dysfunction, and that's just damage to the walls of the arteries. They can't function as well. And then the heart can't pump as well. So diabetes is also associated with a higher risk of heart failure. So all of these things, as you said, the forest fire, it just consumes the body in terms of inflammation and all these other problems that it brings along with it. And most diabetes, type 2 diabetes, is preventable. And you start with your diet and your physical activity, and, you need to exercise, and you don't have to go to the gym to exercise. Just stay in motion, get up out of the chair like I'm going to do after we're finished here, and take a walk. So, do that every day. I read the other day, RC, that only less than a quarter of Americans are getting the physical activity that's recommended by our national guidelines every day, less than a quarter. And look at what we're eating, and we have any wonder that we have diabetes that's, taking over the population. It's kind of an epidemic in and of itself. And then diabetes is also, related to obesity in a big way. And that is also related to heart disease and heart failure. And so all of these things are interconnected. And I think I'm really glad you're doing this podcast, because we need to educate more people about this. So many people don't know. They just think high blood sugar, I'll get it down with insulin or a medication and keep eating the food that I'm eating and keep sitting around and keep smoking or, keep doing these other things. And that's not the way.
So, one of the stories or analogies I tell my patients who come to my clinic with 100 units or 120 units of insulin, but with a hemoglobin A1C of 5.6, and say, hey, my hemoglobin A1C is great. And I'm look at them and say, you are wearing so much makeup right now to look like this. We remove the makeup, you will, your entire face is going to be completely scarred with acne or whatever. This is a lot of makeup, and your blood sugars need to get down naturally. But I think the only difference right now is the newer medications, the Ozempics, the GLP-1s, they work in a different mechanism because they make you eat less, and therefore your blood sugars are coming down, and therefore the heart disease risk and the kidney disease risks is coming down. So that's completely different from the way insulin used to work. And I want people to know the difference between insulin and the GLP-1s.
It is, and that's a really good point, Ozempic and Wegovy. And I think something we have to point out, though, is that when you stop those medications, the weight gain comes back, and the diabetic problems come back too. The blood sugar goes up. So that's not it really is not a sustainable long-term fix. We really have to get people to modify their diets and get active again. And, they can do that while they're on those drugs. Mm-hmm. And then once they go off the drugs, they'll have a more sustainable lifestyle and hopefully can continue to manage things more naturally. But yeah, those are drugs that are very promising. And certainly we've seen they have reduced the risk of heart failure, which we can't ignore. That's a very important thing.
Mm-hmm.
Yeah.
Thank you so much for listening. If you found us valuable, you can subscribe to the show on Apple Podcasts, Spotify, or any of your favorite podcast app. And also, please consider leaving us a rating or a review, as that helps others find the podcast too. I hope you have a great week ahead.